Welcome to the Deep Dive. Today, we're jumping straight into the world of pharmacology. Welcome to the Deep Dive. Today, we're tackling something truly vital. Antiarrhythmic drugs.
Yeah, absolutely critical area.
We've got a great set of resources here, from a department overview, sort of nailing down the core principles to the real nitty-gritty from key pharmacology texts.
Mm-hmm. Good stuff.
Our goal for you, listening in, is simple, but, powerful, to get a clear, sharp understanding of how these medications bring a chaotic heartbeat back into rhythm.
And crucially, when they're the right tool for the job.
Exactly. Think of it as cutting through the complexity to get to the heart of the matter, literally. We're diving into the problem of heart rhythm disturbances or arrhythmias,
right,
and figuring out how these drugs help things, tick as they should.
Exactly. And what's fascinating about this area, I think, is how precisely these drugs target the fundamental electrical activity of the heart. Our sources really illuminate this, starting with the basic spark of each heart cell and then building up to how we choose the best drug for a specific rhythm gone wrong.
Okay, let's unpack this right from the start then. How does our heart manage to beat so reliably in the first place? Our sources detail this amazing process called the cardiac action potential. What's the story there?
Okay, so think of the cardiac action potential as this brief but critical electrical event in a single heart muscle cell.
Right.
It's what triggers it to contract. It goes through these distinct phases labeled 0 to 4.
0 to 4, okay.
Phase 0 is like a rapid on switch where sodium ions just flood into the cell. That causes a really quick change in electrical charge.
That initial spike we see on diagrams.
That's the one. Then phase 1 sees a little bit of potassium leaving. Phase 2, that's interesting. It's a plateau where calcium enters while potassium continues to exit.
So it holds the charge for a bit.
Yeah, exactly.
Right.
It maintains the electrical charge for a bit longer. Then phase 3 is the off switch repolarization, where potassium really rushes out, bringing the cell back down to its resting electrical state. And finally, phase 4 is the resting phase, where the cell actively pumps sodium out and potassium back in, basically getting ready for the next cycle.
So that's the action at the cellular level.
Yeah.
Pretty complex dance. But how does that coordinated dance of individual cells translate into the rhythm of the whole heart? Our sources mention some key electrical properties that emerge from this.
Right. So from those individual cellular events arise the crucial electrical behaviors of the heart tissue as a whole. You've got automaticity.
Natural pacemaker thing?
Exactly. That's the amazing ability of certain heart cells to just spontaneously generate an electrical impulse. They're like the heart's natural spark plugs.
Got it.
Then there's excitability, which is basically how readily a heart cell can respond to an electrical impulse.
Okay.
Conduction velocity refers to how quickly that impulse spreads through the heart muscle. And finally, the refractory period.
The recovery time.
Yes, a crucial recovery time after a cell has fired, during which it can't be stimulated again immediately. It's this, precise interplay of all these properties that gives us that smooth, coordinated heartbeat we rely on.
But when this finely tuned system goes awry, that's when we encounter arrhythmias. According to our material, what are the main ways these electrical disruptions happen?
Well, our sources highlight two main categories of rhythm problems. Tachyarrhythmias, where the heart beats too fast.
Too fast.
And bradyarrhythmias, where it beats too slow.
Brady slow. Got it.
So tachyarrhythmias often arise in a few ways. One really common mechanism is re-entry.
Re-entry?
Yeah, imagine an electrical impulse traveling a path in the heart, but instead of just dying out like it should, it gets caught in a loop somehow, constantly re-exciting the tissue.
Like an electrical short circuit.
Kinda, yeah. Another cause is increased automaticity, where cells that aren't normally pacemakers start firing off electrical signals rapidly, sort of taking over.
Rogue pacemakers.
Pretty much. And then there's triggered activity, where abnormal electrical aftershocks can lead to extra unwanted heartbeats.
Okay. And the slow ones. Yeah. Bradyarrhythmias.
Right. They often result from conduction blocks, where the electrical signal just can't travel efficiently through the heart's wiring.
Like a traffic jam for the signal.
Exactly.
Yeah.
Or it could be from a decrease in the natural pacemaker cell's firing rate. They just slow down.
And our sources also touch on some specific types of arrhythmias that we often hear about, the names that come up.
Yes, definitely. We're talking about conditions like atrial fibrillation AFib, which is a very common, fast, and irregular rhythm in the upper chambers of the heart.
Right, the chaotic one.
Yeah, imagine a chaotic fluttering instead of a coordinated beat. Then there's PSVT, or paroxysmal supraventricular tachycardia.
That's a mouthful.
It is. It's like a sudden burst of rapid heartbeats originating from above the ventricles. Comes and goes.
Okay.
Ventricular tachycardia, or VT, is a fast rhythm starting in the lower chambers, the ventricles, and that can be very serious.
Life-threatening serious.
Potentially, yes. And finally, torsades de pointe.
Another specific one.
Yes, a specific and dangerous type of ventricular tachycardia. It's characterized by this sort of twisting pattern on an ECG, often linked to abnormalities in the heart's repolarization phase, that phase 3 we talked about.
Okay, so we've got the electrical foundation, the common rhythm problems. Now, how do antiarrhythmic drugs actually step in to restore order? That's where the Vaughan-Williams classification system comes into play, right?
Exactly. The Vaughan-Williams classification is, well, it's an incredibly useful framework for understanding how these drugs work. It groups them into 4 main classes based on their primary target.
How they work, basically.
Yeah, how they affect the heart's electrical activity, specifically which ion channels or receptors they interact with in those heart cells.
Let's start with class I then. The sodium channel blockers. What's their general strategy for tackling arrhythmias?
Generally, class I drugs work by blocking the flow of sodium ions into the heart cell during phase 0 of the action potential. Remember that initial rapid upswing?
Right, the on switch.
By doing this, they essentially slow down how quickly the electrical impulse can spread through the heart muscle. But it's not quite that simple. This class is further broken down into IA, IB, and IC.
Okay.
Based on how strongly they block those sodium channels and also how they influence the duration of the action potential itself.
So let's begin with class IA. Our information highlights quinidine as a key example. What should we know about it?
Right. Class IA drugs like quinidine cause a, let's say, moderate blockage of sodium channels. What's interesting is that they also tend to prolong the action potential duration.
Makes the whole cycle longer.
In a way, yes. Quinidine is used in conditions like atrial fibrillation to try and restore a normal rhythm. However, it's known for some pretty notable side effects, including something called synchronism, which can cause symptoms like ringing in the ears, blurred vision.
Synchronism, okay.
And somewhat paradoxically, it can even increase the risk of torsades de pointe, that dangerous rhythm we just mentioned.
Wait, the drug can cause the thing it's sometimes used to treat?
Yes. That's the proarrhythmia risk we have to be very careful about.
That's a curveball. All right, what about class IB, lignocaine or lidocaine as it's often called? How does it differ?
So, class IB drugs have a weaker effect on sodium channels compared to IA, and they tend to shorten the action potential duration, particularly in heart tissue that's been damaged or isn't getting enough oxygen, what we call ischemic tissue.
So it targets damaged areas more.
It has a preference for them, yes. This makes lignocaine particularly valuable for treating ventricular arrhythmias, especially, in the setting of a recent heart attack. That's a really important clinical application our sources emphasize.
Makes sense. And rounding out class I, we have IC with drugs like flecainide and propafenone. What makes them distinct?
Class IC drugs are the powerhouses of sodium channel blockade. They cause a very strong block.
Really clamp down on it.
Exactly. They significantly slow down electrical conduction in both the upper and lower chambers of the heart. While this strong effect can be beneficial for suppressing certain stubborn arrhythmias, it also comes with a significant risk of proarrhythmia.
There it is again.
Yeah, meaning they can actually provoke new or worsen existing arrhythmias, especially in individuals with underlying heart problems. You have to be very careful with these ones.
Okay, that's class I covered, IA, IB, IC. Let's move on to class 2, the beta blockers. We know these are used for various heart conditions, like high blood pressure. How do they specifically help with rhythm control?
That's right. Class 2 antiarrhythmics are beta-adrenergic blockers. Common ones are propranolol, esmolol, metoprolol. In the context of arrhythmias, their main action is to reduce the activity of the SA node.
The natural pacemaker.
Yep, and the AV node, which acts as that crucial relay station for electrical signals passing from the atria down to the ventricles.
Okay.
They also dampen the effects of the sympathetic nervous system, the body's fight or flight response, which can often trigger or worsen arrhythmias.
So they sort of calm the heart's electrical system down.
That's a good way to put it. They turn down the heart's excitability and slow down the signals. They're very useful for controlling how fast the ventricles beat in atrial fibrillation, for instance, limiting the impact of those rapid atrial impulses getting through.
And you mentioned esmolol.
Yes, esmolol is particularly interesting as it's given intravenously, 4V, and it works very quickly, so it can be used to rapidly stop PSVT.
The fast-acting one.
Right. But it's important to be aware of potential side effects like slowing the heart rate, too much bradycardia, and potentially causing breathing difficulties, bronchospasm, especially with the non-selective beta blockers that affect receptors elsewhere in the body too.
Good point. Okay, now we arrive at class 3, the potassium channel blockers. Amiodarone and sotalol are key examples highlighted in our information.
Correct. Class 3 drugs primarily work by blocking the outward movement of potassium ions during phase 3 of the action potential. Remember phase 3? Repolarization.
Getting back to resting state.
Exactly. Blocking potassium efflux here has the effect of prolonging that repolarization phase and thus increasing the overall duration of the electrical event in the heart cell. It also extends the refractory period, that recovery time.
Makes the cell less likely to fire again too soon.
Precisely. Now, amiodarone is a fascinating drug because while it's classified as a potassium channel blocker, it actually has effects on sodium and calcium channels as well.
Wow, a multitasker.
It really is. And it even exhibits a weak beta blocking action like the class 2 drugs. This broad range of effects makes it useful for treating a wide variety of both atrial and ventricular arrhythmias. It's a real workhorse.
I sense a but.
There's always a but with powerful drugs. This broad action comes with a significant trade-off. It has a number of potentially serious long-term side effects.
Such as?
Things like lung problems, pulmonary fibrosis, thyroid issues, both overactive and underactive, and even deposits in the cornea of the eye. Really requires careful monitoring.
Okay, so powerful, but potentially problematic. What about sotalol?
Sotalol is another class 3 drug, but it has a kind of dual personality. It blocks potassium channels, like amiodarone, NED. It's also a beta blocker, just like the class 2 drugs.
So it's like a combo drug.
In terms of its actions, yes. Because of its potassium channel blocking effect, though, it also carries that risk of torsades de pointe we keep mentioning.
That keeps popping up. Okay, class 4 focuses on calcium channels, with verapamil and diltiazem as the main players. How do they contribute to keeping the rhythm steady?
Right. Class 4 drugs are calcium channel blockers, but they primarily target the L-type calcium channels found mainly in the AV node.
The relay station again.
Exactly. By blocking these channels, they slow down the conduction of electrical impulses through the AV node and increase its refractory period. Makes it harder for rapid signals from the atria to get through to the ventricles.
So useful for things like...
Well, they're effective in treating PSVT, that rapid rhythm starting above the ventricles, and also for controlling the rate at which the ventricles beat in atrial fibrillation, similar goal to beta blockers, but working through a different electrical mechanism.
Any particular side effects to watch for?
A notable side effect, especially with verapamil, is the potential for low blood pressure hypotension, and interestingly, constipation can be quite common too.
Okay, constipation, that's different. So that covers the main categories in the Vaughan-Williams system. But our sources also mention some important miscellaneous agents that don't quite fit into these neat classifications.
Exactly. And these are crucial medications that play very specific, often urgent roles in certain situations. Take adenosine, for example.
Adenosine.
Its main role is to rapidly terminate PSVT. It achieves this by temporarily blocking the electrical signals right in the AV node.
A very targeted block.
Very targeted and very short-lived. What's remarkable about adenosine is how quickly it works, often within seconds. It effectively hits the reset button for that particular type of fast rhythm.
Wow. Any downsides?
Patients might experience brief, but sometimes quite noticeable side effects like flushing, feeling warm, and maybe some shortness of breath or chest discomfort. It passes quickly, though.
Okay. And then there's magnesium. We often hear about that in the context of specific cardiac emergencies.
Yes, absolutely. Magnesium sulfate is the primary go-to treatment for torsades de pointe.
The specific treatment for that twisting rhythm.
That's the one. While the precise way it works in this situation isn't completely understood, it's highly effective at stabilizing the electrical activity of the heart in this specific and dangerous arrhythmia.
Good to know. Finally, atropine gets a mention in this group. What's its role?
Atropine is used to treat bradycardia's slow heart rate, but specifically when it's caused by an overactive vagus nerve. We call that vaguely mediated bradycardia.
So it counteracts the nerve signal slowing the heart.
Exactly. It works by blocking the effects of acetylcholine, which is the neurotransmitter of the parasympathetic nervous system, the rest and digest system, which can sometimes slow the heart rate down too much.
Okay, we've covered the drugs, their mechanisms, the classes, the odd ones out. Now, how does this knowledge translate into real-world clinical decisions? Our sources include a table 3.6, I think it was, that directly links specific arrhythmias to the drugs commonly used to treat them. Let's see how it all connects.
Yeah, this table is really valuable for seeing the practical applications. For PSVT, you see adenosine listed first.
Makes sense, the fast reset button.
Right, given its rapid action as the first-line treatment. Verapamil and esmolol are also listed as options, showing how both calcium channel blockers and beta blockers can be used to interrupt that kind of rapid heart rhythm.
Okay, what about AFib?
When we look at atrial fibrillation, amiodarone is on the list, reflecting its broad effectiveness. You also see digoxin.
We didn't talk much about digoxin.
No, it's another drug sometimes used, mainly for rate control. And beta blockers are there too, again, often used to control the heart rate rather than fix the rhythm itself. Shows the multifaceted approach to AFib.
Right, managing symptoms versus cure. And ventricular tachycardia, VT.
For VT, the table often points to amiodarone or lignocaine, again, highlighting those key drugs for potentially life-threatening rhythms starting in the ventricles.
Got it. And torsades de pointe.
For torsades de pointe, it's magnesium right at the top, and sometimes isoprenaline, which is a beta agonist, kind of the opposite of a beta blocker used in specific circumstances, emphasizes the specific treatments needed there.
So, to bring it back to our listeners' original goal, what are the most important things to remember about these antiarrhythmic drugs? If you had to boil it down, what are the real nuggets of knowledge here?
Okay, the absolute key takeaways I'd say are class I drugs, the sodium channel blockers. They're a diverse group used for specific types of ventricular and atrial arrhythmias, but choosing the right one depends heavily on the precise subtype and, crucially, the individual patient's heart condition.
Not interchangeable.
Definitely not. Second, amiodarone is a powerhouse drug, broad utility across many different arrhythmias, but it's absolutely crucial to remember its potential for significant side effects that require careful long-term monitoring.
The trade-off.
Third, adenosine is the go-to first-line treatment for PSVT because it acts so quickly and specifically on the AV node, a real lifesaver in that context.
Quick reset.
And finally, a really critical concept to understand is proarrhythmia, the fact that some of these drugs, the very things meant to help, can actually cause arrhythmias themselves.
The paradox.
Exactly. And the risk of torsades de pointe is particularly associated with Class IA and Class 3 drugs, so that's a vital safety consideration whenever those are used.
Okay. Those are great takeaways.
Yeah.
Now, here's where it gets really interesting for me. Considering this wide range of mechanisms we've discussed, the potential side effects, some quite serious, and the specific arrhythmias these drugs target. What are the big questions a doctor has to wrestle with when deciding which antiarrhythmic to prescribe for a patient? It's clearly not just picking one off a shelf.
Oh, absolutely not. It's a really complex risk-benefit analysis that's highly individualized for every single person.
What goes into that?
Well, clinicians have to consider not only the specific type of arrhythmia they're dealing with, but also the patient's overall cardiovascular health. Things like, do they have underlying structural heart disease? Heart failure, that massively influences the choice.
Right, the baseline condition.
Exactly. They also need to think about any other medications the patient is taking because drug interactions are a huge concern with antiarrhythmics.
Adds another layer.
It does. Kidney and liver function are important too because these organs are responsible for processing and getting rid of these drugs from the body. If they're not working well, drug levels can build up.
Toxicity risk increases.
Precisely. And of course, the potential for the drug to cause new or worsen existing arrhythmias, that proarrhythmic risk we keep talking about, is always a major consideration, maybe the biggest one sometimes. It's a delicate balance, really, trying to restore a normal rhythm while minimizing potential harm.
This has been an incredibly insightful deep dive into the world of antiarrhythmic drugs. It's just fascinating to see how a fundamental understanding of the heart's electrical system is so crucial to using these powerful medications effectively and safely.
Indeed. And hopefully this exploration has shown you, our listener, how these drugs, despite their complexities and potential risks, are really indispensable tools in managing potentially life-threatening heart rhythm disturbances.
Yeah.
It really highlights the, I think, elegant connection between the basic electrical principles governing our heartbeat and the sophisticated pharmacological interventions we have to try and restore its natural rhythm when things go awry.
Definitely food for thought.
Maybe this has sparked your interest to explore the specific nuances of different types of arrhythmias, or perhaps the long-term care of individuals who rely on these medications day in, day out. There's always more to learn in this critical area of medicine.